I hope you can hear me okay. Thanks for having me down there at Texas. Of my favorite cities, favorite shows, you guys down in Texas are one of them, of course. And I want to thank Matt and Jason and Richard Wills and Cade for asking me to come and do this. Before I start, though, however, I just wanted to say that I have two friends in your organization who I'm really good, really associated with, especially Leanne and her husband, Sabila. And I just wanted to ask everybody to give a prayer for them. They've both contracted the COVID virus and are in the midst of fighting that. And if you can find it in your heart, say a prayer for them. They're going to be fighting a little bit of a battle with this. I know Sib especially, and whatever you can do for that, I'd really appreciate it. Anyways, I get rather connected with the people at the cities that I go to, and I just wanted to do that as part of my start here at the presentation. With that being said, I guess the debate is over, so I can move on. The course, of course, is going to be immediate denture standard and advanced fabrication protocols. This is little things that I do and have developed over the last 34 years as a dental technician. Works extremely well for me. And somebody just texted me here. Let me just make sure. Oh, there I am, so I can see myself. Oh, thanks. I look like $1,000,000. Anyways, these are things I developed over 34 years. And so I want to share them with you today. Some you've probably seen. Maybe I hope that by reiterating them, you'll pick them up, maybe even implement them in your practice. Dentures are not replacements for teeth. They're replacements for not having teeth. Famous saying. I think most people who've been around a while have heard that before. So we have to understand there are compromises in what we do with immediate dentures and actually dentures overall. I mean, even your definitive dentures, there's a compromise. We try to minimize the compromises, but one of the hardest things about dentures, I believe, is the immediate fabrication transition. In other words, person's had teeth or some teeth, and now all of a sudden they have no teeth and they have something in their mouth that's foreign, and have to get used to it. And there are lots of ways that we can help in the fabrication of immediates to drive us towards that end. One of them is, I always suggest for the patient and the doctor and myself, is to always recommend a two-phase immediate denture treatment. In other words, one denture is your healing denture, and then we make a definitive denture later after we've done modifications and so forth on the original immediate, and then make a definitive. And you can actually use the definitive denture as a custom tray, because now you've gotten everything worked out in that, and then you take an impression inside of that and pour it up at the doctor's office and send that on. It's a great transition. But we'll be talking about a lot of things. We'll be talking about this is generally the way most people show up or come in resistant to treatment, usually maybe can't afford treatment. Some people are maybe have an addiction, other things, but they come in a lot of different ways, and we have to be able to find different things that we can do in order to figure out what exactly they had before this whole thing started. So despite the significant improvements in tooth retention and the advent of predictable implant systems, and immediate dentures still remain an important treatment methodology in contemporary dentistry. And I said that earlier in my own words. This is more of somebody else's words, but the fact of the matter is that we have a lot of great tools at our disposal, but this is the most important part of this, because it's the first step. Because we have to help them transition, help people adapt, help people accept that treatment. If you've come to my courses before or lectures before, you know that I break them down into segments. So we'll have a foundation segment, phonetic adaptation. We'll talk a bit about surgical guides, some fabrication techniques. I'll show you one case, Jack, how I implemented some of the things to it, and then the end results. So let's hit the foundations, and we'll go from there. So, foundations include, impressions, models, records, mountings, photographs. Big one, photographs. We have cell phones now. We should be able to just take that phone and snap a couple pictures, and doctor send that on to you, and that gives you a really good baseline to start from. You get to see the patient before the treatment starts, and then of course can track through the entire treatment modality. That there is the after effects of a denture impression, for immediate denture impression, that I sent back after the one that I had was remiss, and gave them gave them a custom tray instead of them using one of those stock trays. We'll talk a bit about that. Okay, so we got one-piece, two-piece trays. The one-piece trays, these are for the primary impression, generally on definitive dentures, but on immediates, it ends up being the tray that they use. McGowan, Winkler, Co. They have a provision in the front end, for teeth. They're great for preliminaries, but a lot of times nobody wants to take more than a preliminary because they don't want to yank the teeth out. And I got a couple of suggestions for that. And then they can bend them outward, inward. They're malleable. You can make them fit, but they never really reach the extensions that they need, and they really don't prevent having to do any kind of clinical modification, because there still has to be extensions made with wax and so forth. Because with all impressions, whether it's immediate dentures or if it's definitive dentures, we want more information, not less. It drives me crazy when I get these really remiss impressions and I'm told, well, hey, it's just an immediate denture. It doesn't cut it with me, because just an immediate denture, hey, we need to know where everything is at. We have to have all the landmarks. We have to have everything. And you send me an impression that is remiss in certain areas, hamular areas and so forth, I'll send you a note and say, hey, I need something better, or I can't warranty the case from the get-go. And that's just the way it has to be, because it's really not fair to the patient to try to work with something that's substandard. One-piece trays, light cured materials. We block out the teeth with wax. We make an overlay, put some tissue stops in it. I'll actually have a rim lock in there. You can rim lock the material. They use a little bit of adhesive. You know the drill. This is how they basically make them. If they've got, I should say, if they have people who are qualified in their practice, usually an assistant, somebody like that. I always like to talk to the assistants and give them hints and tips on how to construct these the right way. The first ones out of the block, never really that great. I'm talking about the first case I might do with a doctor for an immediate. It's pretty failing. Anyways, here's the borderline acceptability. I'm looking for a certain extension. I can help make it work for them, but I explained to them what they needed to pick up, hamular areas in particular, full corridors and so forth. It's what I call borderline acceptable. It's just, barely acceptable. Like I said, a lot of practices are really afraid to take any kind of real good impression with somebody who's semi-dentate, only because of the fact that they don't want to yank any of the teeth out. And of course, you got teeth all over the place, and those bad angles kind of lend themselves to extractions. So what I recommend, and what I've gotten from Dr. Campagna, is a two-part tray. There's two ways of making them. You make your trays, we always would with the spacer, but we leave a window with the wax out area, a window, take it off, and leave this open. And then doctor would go ahead and he would either border mold and then take the impression, or take the impression and border mold. But the deal is, it's got a window, and then what you do is you take your material overlaid here. So in other words, in this one here, it has been border molded. Then we take the material, lay it inside the tray. He takes an impression, that leaves a window. And then they take alginate, and they go over the top, and they push the alginate over, and it interlocks almost, but it can take an in and out. And that's not you guys, and that's a good thing. That's somebody else. Anyways, you would overlay the top of that, and then when the impression is poured, this would be readapted. Of course, the alginate is flexible, flimsy, and it's easier to take off, but at least you'll have the area around the teeth, you'll have the teeth intact, and they won't be extracted. It's one example there. Here's another example using a low viscosity material, uh, PVS. Go over the top of the make sure it's entirely covered, and then take the impression over the top of that. When they pull the irreversible hydrocolloid off of there, this will stay in place. Then they can peel it off of the teeth and reinsert it into the impression, and then you can pour up the impression. Two ways, or two simple ways to facilitate an impression on these types of patients. I know some doctors just take and wax the dickens out of them. You know, I'm always concerned when I cannot see the CEJ, cannot see the emergence profile of the teeth. And if this is all blacked out with wax and obliterated, it really gives me no guidance on a way to trim the case. So for me, these kind of things work best where I have, a two-part impression done, because I can, then at least I can still see where the teeth come out of the tissue. So I know that when I'm doing my bone trim on the models, I have some guidance. Otherwise, I'm shooting blind. And then I have to leave a lot more on there because conservative is better in these cases. Just an example, I'm proactive, not reactive. I get a little note here, please fabricate upper healing denture. Healing denture, that's the code word for an immediate. And you can see the thing is just, it ain't happening. It's not there, And they also sent me a triple tray, which, hey, they sent me a triple tray. What can I say? So I fabricate a new tray on top of this, a custom tray, block out everything. And this is basically, I put a hole in the middle just so I could vacuum form over it and get myself a spacer. But the bottom line is, are you guys texting me again? Did you lose me? No. Anyways, what I had here to start, here's what I got back. I love this line, custom impression as per your request. See, I'm driving this whole situation right here. And by the way, I can still use this for my registration. You just cut out that material and then trim away all the excess. So basically what you have is pinpoint contacts, and you can articulate the case using that. So, again, being proactive and not reactive, not going, okay, doctor, anything you say, I'll just do it. I say, hey, can you fabricate I'm going to fabricate a custom tray, and I'm going to have you take a new impression because I can't warranty this. And that usually is a good trigger point for me, because when I say I can't warranty it, then they think twice about having me work off of something like that. So here's the before, and of course, like I showed you earlier, here's the after. And you can see much better, something to work off of, got all the landmarks I need, good vestibular extension and so forth. But without this is what I would have been forced, I would have had to been forced to deal with that thing on the right. And it's hideous. And so, again, take the bull by the horns. You just want what's best for the patient. You're going to hear me say that a million times because I'm a patient-centered laboratory, and that's the way I operate. So anyways, we got a nice result now. We can move forward. Lower, please construct immediate dentures. Again, I wanted just to show you here. I get these routinely, and I just turn around and make them a custom tray and send it back. And I always tell them the same thing. I need more, not less. The more you can pick up, the better, not the less. So anyway, you can see. It's a point of fact here. When you see these red marks like this and I'm doing all this, do you know what these are? These are the communication tools that I'm using to send back to the doctor and say, hey, here's what I got. How can they expect me to work on that, This way I don't have to argue or anything else. I just show them the pictures and say, come on, I've got to make you some trays for this. And by the way, we can't really waste a bunch of appointments nowadays, because with all this COVID nonsense going on, I mean, they can't have 3-hour appointments, because 3 hours worth of appointments could be 3 patients. So, let's maximize our time in the operatory so that you can get it done and move on to the next phase without having to go in reverse and then go forward again. So for model work, I prefer the CoCal. I've always liked CoCal forever. It's got a 0.13% expansion. Is that good? Yeah, I guess it's good. I don't have any problems with it. I've been using it for almost 34 years. Initial set is 15 minutes, 40 minutes before I can then working on it. And if I want, I have a dryer that I modified that I can dry the models and I can get working on them even quicker. Remember, if you don't use the water to power ratios, which is 100 grams to 30 milliliters of liquid, there's no way that you can have any kind of baseline to discern the quality of your work. You can't complain about something not working right if you're not using the product correctly, okay? When I'm using, by the way, you'll notice I box all of my cases. I don't care if it's a reline, immediate denture, full denture impressions, whatever it is, I'm always boxing and pouring my impressions. I use Wonder Admix from Dental Creations along with the Wonder Fill material to do the boxing. I use the Admix in place of water, so in other words, instead of 100 grams of 30 milliliters of liquid, that liquid's not water, that liquid is Wonder Admix, which has a self-wetting property to it and it also makes nice smoother models. Okay, you can see the models that I have. And hang on, just making sure. Okay, Kate says everything looks great. Anyways, I also box my master impressions, as I mentioned to you, with the Wonder boxing system. Let's move on. I have a little Taylor scale, by the way. You can get these on Amazon. Taylor, I use that little scale for just about everything. I measure out my powder and liquid ratios for everything. It's just an easy tool, about 28 bucks from Amazon. You'll notice that this Wonder Admix bottle is like a gallon, but actually it's empty when you get it. You only get the product in this little syringe, because if they had a gallon, you'd have to pay for shipping for a gallon of the Admix. But by having a concentrate, squeezing it into the bottle and using it that way, you're only paying for the weight of an empty bottle and the Admix product itself. And again, you would just syringe or pour that right in and then add water to it, and that would be your liquid that you're using for your model work. I love it. Works great. Bubble free, beautiful models, nice and smooth. Along with the Cocal product, it's a winner. The boxing system, if you haven't seen it before, it goes like this. That little frame locks in place. This material is Wonder Fill. And what I do is I submerge the impression into a line that I have drawn on the outside perimeter of that impression that gives me a good vestibular depth. And then when I insert this into the boxing material, the Wonder Fill material, I do that up to that line. That way I'm assured that I have a uniform depth of corridor all the way around and a good exposure and depth of the full sulcus. Okay. And so the nice thing about this is that it inverts the impression so they're up. And so the stone rolls in, runs in real nice, adapts really nice, maintains the impression borders. There's very minimal trimming. You know, this would be trimmed into, trimmed back to where the land area is, but it's very minimal and it's very fast to perform. If you're not using the product, jump on it. The two products, actually, the Wonder Fill and the Wonder Admix, two nice companion products. I use it for everything from denture, regular conventional dentures, all the way down to my hybrid bar cases. That's what it looks like. The product is really nice and creamy. But, I've also bought myself a Nesco food dehydrator, which I took the racks out, left the center spine and the lower rack. And what I do is after I separate the models, I stick them in this food dehydrator. That accelerates the drying process because I don't want to have any soft areas on the model and I want to get going on it. So this works really well. I also use this when I'm coating models with separator because I like to keep the models warm through coats of separator. In other words, when I start to do the separator on my cases, this would be if I was packing cases, I do the first coat when it's warm, when it comes out of the wash, you wash it out. And then I keep the temperature warm in this and it dries the model surface. And then I paint at least one or two, I paint at least two more coats on top of that model and then stick it back in here. It shortens the period of drying time to about 4 minutes per coat. And that moves the whole process along. If speed is something you're looking for, and a lot of people are for production value, that's a good way to do it. I use it for anything I got to dry, I put it in that. And by the way, you'll notice it has variable temperatures. So you can set that temperature at the right temperature and not overcook anything too. If you use slurry as a setting accelerant, and I know old school wise, I was taught in school, well, you could always use a little slurry. That'll really speed up the process. There was some conclusions done by a research that showed that sure, it speeds up the setting time, but there is an increased to a pronounced level in the first 24 hours when slurry is used of expansion, and unexpected results may be faced when indirect restorations are done in this period within this period of time. So there's lots going on there. It takes a while for that, the model to settle down, so the expansion isn't so great. So I think that really lends itself to the drying process that I do, because I'm speeding up that 24-hour, process. Anyways, something to consider if you're using slurry. Little mathematics here for you. 100 pounds of co-cal cost me about $118. 100 grams per models I showed you. 453 models basically I can make from the 100 pounds at 26 cents a piece. So 453, and I resell those for about 15. Well, actually, $15, round up. It's $66 or $6,677.22. It's what I call profit made simple. You're making a lot of profit. Now, if you charge $20 for the model, you make more. If you charge less than $15 or $14.75, you make less. But you can see this math here. $14.75 was determined by the LMT fee survey, and that's what I use to come up with an average. So it's not bad. For $118, you make $6,400 and some change, which isn't bad off 100 pounds of stone. So if anybody tells you can't make any money doing analog analog work, they're wrong. You can. I could show you tons of math about acrylics and everything else. Anyways, here's something also to consider when we're making these immediate dentures, and that is that I always try to ask the doctor to give me a clinically indicated border for the post dam, because research that I have seen and have read says that the reliability of the fovea, which is what we were taught at school to mark our posterior border, is an unreliable guide for locating the center portion of the posterior border of the maxillary denture. I'll show you what I mean. In that research, it said when present, in other words, when the patient had fovea that you could see, it was indicated in the model, only 25% of the subjects lay directly on the vibrating line. In other words, if we're using that to decide our vibrating line, it's only maximized. I won't say it's only right. I'll say it's only maximized 25% of the time, because it's generally 1 to 2 millimeters posterior of that line. On 18% of the people, 2 to 3 posterior of the vibrating line, 27.1% within 3 to 4 posterior of the vibrating line, 16% within 4 to 5 posterior to the vibrating line, and 1.4% or more are 6. So what that tells you is that line is wrong 75% of the time, basically. And if we can get a palpation in here with the nose blow technique, and we can the doctor can inflate that area, then guess what? Then we're looking good, because now we have a clinically indicated one. A lot of people like to mark them at that line because they're worried about people gagging, but believe it or not, they gag on them even forward. I've had patients that had a denture. The doctor was making them a new one, and the guy I was working with was a person who palpated that vibrating line and found it, marked it, and we actually extended it beyond posterior of the fovea, and the patient had no problems with gagging whatsoever. But they were constructed that way for that reason, because they were afraid that the patient was going to gag. But if they're made right and designed properly meaning that it tapers to tapers down. It's not like a thick wall at the back too. That has a lot to do with as well. The design of the posterior of the denture is also lends itself to acceptability. If those things are in place, then this is going to work out wonderfully, because you're going to have the exact place where the border should be, and then you can carve your post dam from there. Enough said. Records. Oh, by the way, worth mentioning, when you're cutting your post dam in there, See this here? That's a hamular ligament. It's on both sides. Some patients have them very pronounced. And with those in place like that, what you do is when you're carving that post dam, you terminate it, to the back side of it. Okay. You don't go over the top. In other words, you don't roll over the top of that ligament. Why? Why do you say would you do that? Because those ligaments get taut when the patient opens wide, and they expand because they're a ligament. Okay, and when they expand, they pop the denture. So just keep that in mind. Okay, to terminate it right there, right before you get on the ligament. All right. At least this is what the things that I do. You might think that I'm full of, but I'm not really. These are things that I've experienced, and they're things that I do. If you want to continue to go over the top of that hamular ligament area, feel free. I'm just giving you some advice, some things that I did to help drive a case towards success. Every situation is unique. It really is. So base plates, if I have semi-dentulous patients like this, I always suggest something in order to hold the base plate in place. Wrought wired clasps. I don't want this falling down when they're taking records on the patient. It's inaccurate and drive you crazy because you'll never figure out why you can't get the bite right. Then you finish the case up, and then the patient's it's all over the place. I also use the Gebde bite wax for the blocks because it's hard. It smells like pineapple and coconut too. Patients kind of like that. Not that I have a problem with it either. I kind of like working with something that smells like pineapple and coconut. But the fact is that it's harder. It's when it sets after it's notched and after it's been modified, it sets hard, and it won't distort. And I send a lot of cases out. I send all my cases by FedEx or UPS. And with all the heat differentials, it's nice to have a nice stable hard wax that works well. Also, the white is not off-putting as a pink block would be. It's a little bit more biologic, if you want to think in those terms as well. Those rims, they're from Gebde Dental, in case you were wondering. They're vanilla. I think they smell more like coconut and pineapple, but they got a weird smell to them for sure. Anyways, I got standard and double X heights. Okay, heights being here. I don't go with the double X heights because I already find them to be more than I need anyways. 22 and 18 is our number, of course, for thicknesses from the vestibular area. And so because of that, I'm always melting the dickens out of it. And I think that using more, one that's higher, it just means you're going to be doing more work to modify it. So anyways, higher melting point than the base plate wax and hardens and holds the indexing well. Here's an alternate retention means. There's a lot of ways of doing this. This is the one way that I do it. Okay, so you make yourself a base plate. You got these teeth there. So what you do is you take and cut windows out along this way. And then what you do is I use a GC Reline or extra soft. It's cartridge fed. And basically you prime it. This is, and by the way, I should take a step back. I use acrylic, self-curing acrylic base plate material. It's not self-curing acrylic, but it's auto-polymerizing resin, which has a nice pink color to it, which I like. And it sticks well to this material, the Reline material. But anyways, I cut out this window, and then I inject, and then just wet my finger and press it in so that it goes underneath the undercuts all the way around. This gives me a stabilized base plate. It snaps in. It only has to go in once or twice. And if there are major undercuts, which usually there are in these teeth because there's been gingival recession, and so you have like a big undercut there, they lock into place kind of nicely. And if you have a big undercut here, you could, on the underside, you could hollow out a little area and squirt some of that material in there too. And so it locks in here, it locks out here. So it has cross arch retention and then something on that front tooth. It's a great way to stabilize those base plates because I'm trying to help the doctor and I'm trying to help the patient so we don't have any problems because we're going straight to finish. We're knocking teeth off and we're finishing the case. I got to make sure that I have all of that stuff behind, like I have a baseline set up. And so because of that doesn't drop, the chances are much better that we're going to have better records. Just an example, I always, even if they're not restoring the lower, I insist on a rim With blocks, even if it's one tooth here and one tooth here, I need indexing. I don't want just tooth indexing. I want the whole banana, okay? I got to have that. And here's what you get in return. Trimmed bite, put it in place, gives me what I need. And then I'll start to take photos to confirm where the first tooth contacts are and double check to make sure that that's where they are with the patient. All right? I mean, this simple stuff, I just reiterate it. I go back to it because you know what? I see stuff all the time and I go, why did I forget that? Posterior support, no warranty without it. In other words, I'm not making an immediate denture when the guy is semi-dentate on the lower, has no posterior support, and you're expecting me to make a brand new immediate denture for the upper. It's going to get beat to dickens and fall apart, and I'm going to get blamed for every repair, and I can't do it. You've got to give me posterior support, okay? No warranty. And I tell my clients, and they understand. They understand that I can't warranty something like that. That'd be like putting tires on a car, not tightening the lug nuts, you know? Not going to do it. You know, and I get these things routinely, and then I have to send it back along with a rim on it and say, please retake the bite registration. Just the way it goes. Dentures without opposing posterior cross-arch support cannot be warranted. Again, I can't reiterate that enough. Can't do it. Can't do it. So then he sends, that's that same case. I sent that to him, and I get this back. And some grumbling, you know, okay. But I now have a good registration, and now I can use this rim as a tool to try to drive this treatment to a better place. By the way, I know you believe that you understand what you think I said, but I'm not sure you realize what you heard is not what I meant. Say that 3 or 4 times fast. Think about it. But this is sheer crapola, and we don't do crapola in my laboratory. And you can see what that registration revealed. I took a picture after it was mounted, just even though I knew it was already wrong, because I had to emphasize why. And what do you think they told me to do? Just open it up a little bit. I think if you look at the pictures, I think that you're going to understand that I can't just open that up because it changes the plane of closure and all kinds of other stuff. We need to have rims with blocks, and then you need to take a nice registration for me. So, I get a case like this, and again, this was a case where they said, we just need an immediate denture upper, and we're going to figure out what we're going to do with the lower later. And I said, no. We pushed back and forth. They got them a tray. They took a nice impression for me. I took and made blocks, and I said, listen, since I got the blocks on there, I'm going to do something for you, and I want you to show the patient. So anyways, he took the blocks, took the impressions, put the notches in, took a nice bite. I got that, okay? You can see why I didn't want to warranty this case. The patient's going to come back in a year or whatever it was. I can't exactly remember the details, but they're going to come back, and then, we're going to take care of it then. Because that denture up above is going to be beat to dickens, and I can't fix it a dozen times. I'm just not going to do it. It's a waste of time. It's a money loser, and it's a bad will thing with the patient. So anyways, he gives that to me, and then, I have those in place. Now, this is just another case just to show you an example, but I built the blocks. I use a straight edge to get myself a plane that I'm going to need because I'm going to make this ideal. It goes back for a bite registration, and when I go to send it back, I put teeth on that registration. Those teeth are not like teeth. Those are self-curing duplicates of denture teeth that I would use in opposition to the denture that I'm fabricated on the maxilla. And so that'll go back, and I tell the doctors, hey, use this as a way to illustrate to the patient that he needs to have posterior support. And I tell them to quote me even. So, we do this. We have this. These are self-curing teeth, believe it or not. And what we do is we put those on there, and it goes for the try-in, and then I tell the doctor, I ask the doctor, I don't tell the doctor, I ask the doctor, please show the patient that they need to have posterior support. Tell them I cannot warranty the upper denture, the immediate denture. However, if they'll go along with this treatment modality for a reduced fee. I use self-curing resin teeth for a couple of reasons. One, of course, is the cost factor. It costs a nickel a tooth, not even. It's more about the patient. Uh, the price of treatment is I'll use like microwave cured a resin. I can do it really quick. I just add a couple clasps and it's done. But the patients generally about 75, 80% of the time say, you know what, I can do that because if the guy's not going to warranty it, I got to have something. And here's the other, I remember now what I was going to tell you. The other thing is that they wear out fast. Not real fast, but they wear out within a year because they're only self-curing resin and they're up against, IPN or hardened nanocomposite hybrid teeth. So they beat it up and it's gone. I always get that one, don't make it too nice because the patient won't ever come back. Well, I make it nice, but I don't make it so it'll last, okay? And so eventually a patient definitely cannot go forever with that, and they'll have to come back to complete the treatment. You guys have seen this before from me. If they've got a partial denture, we're making an immediate denture against. Obviously, this has been made at a lower plane because of all the supereruptions that's gone on with the upper arch, which is failing. And so I always make these little segments. I make these kind of very rudimentary segments to do my setups, to get the plane of occlusion correctly. And then I tell the doctors after the fact, once you take and glue those on the partial dentures as an immediate adjunct to the treatment so that you can show the patient we have to bring the plane up so you have a better chewing surface. And then down the line, we'd like to take and skin those teeth and saddles off of that partial and refabricate for you something that's brand new on the bottom, except you won't have the costs of the frame. It'll just be teeth and the processing setups of the teeth. Works extremely well, and I'll tell you what, generally they're one and done. I get it back with a bite registration, skin them off, set it up, process and finish, done. It's a one sequence deal. Because patients already work themselves into a certain situation, once these are in place, they get used to that occlusion. It usually has little pinpoints and stuff on it where it's been worn in. It almost doesn't even need a bite in a lot of cases. And then we just get those, skin it, we get the real thing, skin it off, and complete it. I also, as you've seen before, I also make the faux teeth like I was talking about earlier. I just use PVS, polyvinyl siloxane putty, and I just impress the denture teeth. This technique is better than this one, and I'll tell you why. Because a little box has walls, and when you go to squish these into just a rope of PVS, they tend to, it doesn't stay to the walls, it tends to kind of peel away, or not peel away, but it pushes away. But by having it boxed like that, where I have the box and there's walls to support it, it doesn't distort. I got a bit of distortion on these. These, they don't distort because it's a little box and those walls to hold them in place. I make a ton of these, in my free time. I have the mold. I leave a little lump on the top so I can pull them out in one bar, and I break them up and throw them in a box based on upper, lower, molar, bicuspid, blah, blah, blah. Usually I like to go with the lightest shade, which would be an A1, because I use the GC has that Optiglaze A+. And so what I can do is by painting coats of A+ on there, I can take an A1 tooth and turn it all the way to an A4 if I want. And you have not seen that before. I have videos on it, and I also teach courses on that as well. It's really a fast way to do it. I actually use up a lot of my broken set inventory the same way. When I have repairs to make, or even when I have provisionals that I'm making, a lot of times if I have the tooth in stock, I'll take it, and if it's not the right shade and it's a lighter shade, I can darken the shade and use up my tooth inventory. And the cool thing is I get to charge for it twice. The first time when I bought the set and it was broken and the doctor didn't want it, and I threw it back in my inventory, and the next time somebody else needs something, I get to charge for that tooth again. So it's a double charge. So anybody listening to me out there, I'm profit driven because I'm a business. But at the same time, I'm fair. We're in this to make money. This isn't a charity. Here, this one here, corrective indices, what a nightmare. Just, chewed down to nothing. And I can't make an immediate denture to something like that. So, I'm not that good at crown and bridge. That's why I do dentures. So I make these little like segments and they actually look like teeth. Really, you don't have to worry on the lower about this area, because what I'm really concerned about is when they view, when they look down and they see an occlusal area, that that doesn't draw anybody's attention. Like, I know this isn't to shape and form here. I want it to be robust enough to hold up. It has to be glued on or to the saddles, to the teeth that are already existing. So, doing it this way with that with with that um, um, with that occlusal pattern there, at least it doesn't draw your eye to it, especially like I say, if you're looking down at it. But you can see, I just darkened it with a little bit of optic glaze. It's less than a provisional. It's just a way to move the patient on to the next phase of treatment. And again, once this is made, and perhaps even when the definitive is made on the second stage of the immediate, then we can go back and scan all that. Here's just another example. Those are just faux teeth. They're just made out of self-cure. I can't help myself. I like to make it look pretty. I made this little funky clasp arrangement to hold it in place, another clasp arrangement here, just something to give them posterior stop so that I can warranty the appliance. Made one here to even ask for me to put the It's a Clear clasp on there. Again, though, these are just self-cure resin teeth that I take and dollop. It doesn't take long at all. It's extremely simple. And I just add that optiglaze to it and they're ready to go. And by the way, because these are microwave cured, they're ready to finish in under an hour. And I am a firm believer in the microwave, and you people who have seen my courses know I rave about it because it's an excellent production tool without a compromise. There is not a compromise. Again, I use a flat plate and I lay it across when I'm arranging the occlusion to bring it back up to a normal level. And you can see this is that same case I showed you here, that last slide back. Here's another one, same thing. Oh, provisional teeth, a nickel, microwave cured in 48 minutes, threw a couple clasps on there, one and done, drives the patient towards the next thing. And you can see that I haven't just started doing this. Here, 2016, that's 4 years ago. And believe me, I've been doing a lot longer than that. But again, this is how we drive this whole immediate denture thing to a better conclusion. And just to show you, again, same thing, faux teeth. It goes back, doctor shows the patient, can't warranty it. Bingo, let's just convert that. I go, absolutely, easy to do. Bite trimmed, confirmation try-in, and we go from there. If you're not doing it, the most necessary tool in your laboratory should be this documentation area with photographs. Now, I do it this way. You could do it with a phone and a little piece of black cardboard paper. But the fact of the matter is, you got to have photos. The guy climbs up on my roof to quote a roof. He goes up there with a camera. He comes down. He goes in his van. He prints up pictures of what's wrong with my roof, comes out of the van, shows me the pictures. I mean, the most rudimentary way of showing a situation. If you're not using photographs, why? I mean, maybe the doctor doesn't want to, but you got to convince them, because this is what drives cases, whether it's definitive work, immediate work, hybrid bars, anything that's got a smile where you got to set teeth. This is the way to go. It's a great way to document when you see something that's not right, like I showed you here in these pictures. You get missing hamular notches, remiss impressions. It's a great tool. That's my old cell phone. It was a little tricky because I had to adjust the focus around the rubber bands, but otherwise, yeah, it was okay. It was, a step in the right technological direction. Just saw that. I couldn't get enough of it. Analyzing for tooth position. So, we use the pictures, but if you don't use the pictures, here's what you should be looking at. First contact. Once you mount the case, you should be looking for where is that first contact in the bite, and how does everything else touch after it reaches first contact. Once I see what's in first contact, then I know that I'm assured that from this point, then I can start working on things like bringing these teeth down. I should go back. Bring these teeth down. I tried it with a hand articulation. Well, actually, I tried it with hand articulation and I couldn't because see here, these are super erupted way up high, and you can see where I had to set the teeth. So I called the doctor's office and said, hey, I'm going to take the first contact. Here's the picture. He says, okay. I said, from this point, I'm going to take and move those teeth down because these have super erupted. I'm going to grind these down and I'll mark them in red to show you, the difference in the length and then where I'm going to bring it. He said, okay. Then here was the second or first contact on the cross arch side. So that side and that side both touched, and that assured me that we could come down. I could take these down and bring these down. Okay, because pretty much first contact is going to dictate, contact of occlusion. When I'm setting the cases up, it gets really confusing because the gingival course, you can get lost in it, especially if you got all kinds of up and down stuff going on. I need to have a baseline so that all the gingival course, I can see it. And the best way to do this is just take a piece of black construction paper, cut it into a strip that can wrap around the model, and take a rubber band and put it in place, and then pull it down and adjust it to where it comes to the gingival zeniths on these teeth here, to give yourself a baseline for how much tooth is going to show in your arrangement based on the occlusion, of course, and your anterior overlap. But this is a great way then, because you won't lose that orientation. And if you're going to take it off and do waxing in between, which you will do, what I do is I take a pencil and just draw a pencil line using that. And then when I go to put the piece of construction paper back on top, I have an orientation mark so I can put it right back where it was so I can continue on with the arranging. See what I'm saying? Again, this is a very rudimentary tool, but it works like a charm because it gives me the baseline. And immediates, we're trying to establish something that's gone awry, and we're trying to bring it back into normalcy, and this is the best way to do it. And then what I'll do is take an occlusal plate and double check to make sure that I'm a third up the hamular notch or a third up the retromolar pads there, and that I've already set my lowers here to kind of give me an idea of the plane. But it's working out pretty good, and that's taking me to the conclusion. And again, I take photos of this. If I ever get a question on, hey, how come that occlusal plane is up, down, or maybe so, whatever, I can say, here's a picture. Here's what I took. Here's my setup arrangement. Most of my accounts look at that and go, yeah, okay, because they know that I'm documenting it. They know that I'm using the best tools. I generally do not get anybody. Years ago, I stopped getting people asking me, did I do something different? Because this stuff keeps me on page. It really does. So, compare to reality, because I get photographs, I can compare this impression to reality for this immediate denture patient. And I can see that there is an intact mesial distal incisal corner here. And so if it's that way here and it's that way there, then I know that when I go to set the plane, if this is intact and not worn down, broken down, or super erupted, I know that's a pretty safe bet that that's what's going to dictate the plane. So once I can find myself, and I can estimate it, and then I can maintain that plane, again, using a flat plane, like just a little template, handheld, I stick it in place, and I continually check to make sure I'm not losing it. So between this plane being maintained and that black piece of construction paper that I wrap around there, I'm trying to get as close as I can to what they had before there was a total mass destruction of their dentition. There's occasions when I'll also use just a wrap, I'll do some indices on the front of the model, and then I'll wrap some putty around it, and then I'll trim it. And then what I'll do is I'll continue to trim it down until I get just the incisal indices, and I'll use those as my guideline. And a lot of times I'll contact the doctor, and I'll say, hey, listen, here's what I got when it's, when I have it mounted. Here's where the incisal edge course is at. Do you want me to maintain that? Do you want me to bring it in, tighten it up? What do you want me to do? Because I notice this is bridge work here. You can always tell bridge work. And by the way, when you're doing immediate dentures, you should always ask the doctor to, you should always have the doctor indicate where your pontics are at. Because obviously when you're trimming models, you're not going to trim anything away from the pontic surface at the tissue. because there will be no resorption. You'll want to take it right off at where the pontic stops, okay? And most of those pontics are ovate, so at the depth of that pontic is probably at the crest of that. And that I wouldn't go any further. I wouldn't remove anything else. But it's important that you're indicated, especially if the patient's got a lot of failing bridge work, which ones are the pontics. Okay? Just helps in you trimming. We'll talk about that too. There it is, the maintained positions. You can see I got the teeth set up with it right on. I opened it a little bit just so you can see, but you can see that I'm following those indices in that way. And I also have marked the length on the model, to give me some guidelines there as well. Always guidelines. Lines dictate, lines show. Midline isn't in the middle of the tooth, or it's in the middle of the tooth. It's not at the natural midline. All of these things need to be in concern. And the reason I know that is because this was bridge work. So I know that that's the way it existed when it was built in the bridge work. So I'm maintaining that here. Okay. There's that fella. I can't remember his name, but I got that picture. I knew that was intact. I knew where he was. I knew where they had opened him to a certain freeway space. These maintain, by the way, you'll notice these putty indices. When I have the case mounted, I make these 2 putty indices and I make them back here and I make sure that they're really stable. Then when I start lopping off teeth off the model, I don't have to worry about the orientation. I always have it, at least a check here, okay? Because a lot of times, you close the articulator, and even if you have a pin, the pin gets in the way. So it's nice to have something that holds it in its position and it keeps the pin out of my face. So then I can, set the teeth the way I need to set them. Okay, just another little tip, working tip. Here you go. There's that contact information I was talking about, confirmation. You can see here, contact. You notice something? Patient's already still losing teeth, man. He's still got that. He's still got a lateral. He's still got a central, but he's already lost a tooth here, and the stuff is starting to migrate as well. But I still have a contact here. This contact migrated forward over to here. Notice. So, but I still see this one, and that's what I'm looking for. I'm looking for at least one that's still intact. That was that first contact area. Like I say, this is gone now, and it's over here. It's moved. But that's because he had teeth here too to contact into. Okay? So you can see mobility and loss is continuing during the course of treatment even. And that's why it's important to identify, maintain these kinds of landmarks so that it takes you through the case a lot. I know it's a lot of work. You're thinking, oh gosh, man, it's just an immediate denture. But I don't see it that way. It's just not an immediate denture. It's an immediate denture. It means that it's immediate. It's going to be immediately life-changing. It's, this is what what you should always keep in the front of your brain is that, that patient there never experienced losing all their teeth. He's been trying to hold on to these things for eons. They're going. He's going to have to adapt. And I mean, really, you should be always thinking what is, the best, highest best. Even if you're not getting a lot for it, then ask for more because, this is an important step. It's like taking a person's leg off or something and then giving them something horribly ugly that doesn't work and going, make do. It's, to me, this is worse. Well, not worse, but it's different because it's in the front. It's what you project. It's who you are. It's your smile. It's all that. It's chewing. It's eating. Gosh, I can't think of anything more important except eyesight. We can't restore that yet. Anyways, that's that case with the migrating, drifting, but you can see I've maintained. I've got contacts. I've made markings. I know where this cuspid tip is at. I'm going to be knocking stuff off. Again, though, I always go back to I'm using that plane. I'm using that plane to establish and maintain through the entirety of the construction. Too wide, wrong shape. Here's an issue that comes up quite a bit. So you take your calipers like you've been taught and you go like from here to here and you measure that. And then you go to start making an immediate denture and it's like, ooh, when it's done, the patient's going, oh, those are too wide. You can even be that. I mean, it's too wide and it's just not the right shape. And I'll give you the reason for that. The reason is that there are line angles. See that line angle right there? the line angles on the facial, it's mesial facial, distal facial, mesial facial, distal facial line angles of these teeth are really what dictate the width of the tooth, not the contact area to contact area. Because if look at a denture tooth sometime, take a crayon or something and drag it across the highest point on the tooth and you'll find the line angles, okay? And so when you're measuring to get a tooth to replace something that's going to go on an immediate denture, measure from the line angles and from the CEJ. Even if this is exposed, don't measure where there was resorption. Measure where if you can see the outline of the tooth, measure from where that CEJ is at to the incisal edge. Take into account that there could be incisal erosion. But when you're doing your measurements, realize that what projects the size of the tooth are the line angles and not the contact points. Because when you pick the contact points, you get a wrong tooth. Then you have to look at obviously the incisal edge course, and then this would be a phone call. Do you want them rounded, or do you want them squared? How do you want me to treat that? Because I'll take a rubber wheel and then I'll take and modify that tooth once it's the right size to the right shape. And again, more information that I need to have. But again, see, measuring from the line angles and not from the contact points. When I'm trimming the models, I never take anything off of the back side. I never take it off of the palatal area. I leave that intact always. And everything is reduced from the facial aspect of it here. Now this was René Lecour. This was his diagram, and this is what he recommended. But this was in the early years. I've kind of advanced to some other stuff, and let me show you. There's a model trimming. There are three philosophies, and I have found that over the years, I've identified the fact that two of these have been bastardized into one kind of a melding of philosophies. One is socketed and the one isn't. And then there's a third one, which is brand new or relatively new in comparison. And it's called spatial modeling. But, there's one thing here that you got to remember, and that is for the best residual ridge, it is desirable to conserve, main word, and maintain as much of the bone structure as possible. Many immediate dentures should be inserted with the surgical procedures limited to the extraction of teeth. In other words, there should be no bone trim or anything else. You pop the teeth and stick the denture in. So that is kind of what, that's the thrust. That's what we kind of work towards. That's what I'm always working towards, and I'm always keeping in the front of my mind. So you got the standard method, and it's because it's named from the doctor standard, Stanley standard. I think some people are under the misconception that the standard method would be like saying that that's the default method or the only way to do something. And then there's the Jerby method, which is Dr. Frank Jerby, and his method is different than Dr. Standard's. By the way, you jot those names down, do a little research if you want to further know more about this. And then there is a spatial modeling technique from Drs. Phoenix and Flegel. Okay, so let's take a look. So the first one we got here is a standard one, and you guys mostly know this. First, we slick off the crown, okay? And then in turn, we scribe a pencil line on the facial surface of the cast. That's about 2 millimeters apical to that line identified as the facial gingival margin. Facial gingival margin. See how it's marked? And then it's trimmed. Standard placed a third pencil mark here on the facial surface to indicate the beginning of the undercut area. So this is I would consider this to be rather conservative, and it's pretty much the way I do things. Now I've had doctors ask me to do the Jerby method. Let's look at that. The Jerby method is cast modified by first slicking off the tooth, and then socketing. Okay, socketing. Everybody, I've been asked to socket many times. Socket it and then trim it back. Okay. But socket it to the line denoting the junction of the cervical and middle thirds of the facial surface here. This is face 1, 2, 3, it's three sections, right? Third, cervical third, junction of the cervical and middle thirds. This is middle third. This is the facial surface here. See it? So anyways, that's a third, that's a third, that's a third. So they take and mark the line from the socketed area, and then they trim off the facial from there. Midway point is described. Floor of the prepared sockets is extended lingually this way. See it there? They take and extend that lingually. G, okay? Stone contours are gently rounded at the facial, and lingual surfaces, just here and here, just here and here, rounded just a little bit here and here. And the resultant reduction is shown. Here's the reduction. Cross-section view of the tooth placement and the denture-based contours proposed by Jerby. Okay? The reason I do this is take a little bit of the undercut out. But you can see they use the socket with the remnant of the socket, the facial third, down to the middle third, and then round the area off, and then don't round this off, just take this off straight. Okay? In other words, don't round it back like that on the lingual. Just come straight across and knock it off. Because then if you were to do this, then what you're doing is you're removing palatal bone. Okay? All right. And you can see the result here. And then the third one is the spatial way. And spatial is, here's your face. They got this flipped around, but basically, again, tooth is removed. From that junction point over is 2 millimeters, and then from here down is 4, and that's where you make your mark, and then you trim. So it would be from here, from that point, that extraction point right there, the wall, forward 2 millimeters, and then 4 millimeters down, mark it there, and then round it from there. Let me go back. Shoot. Then on the lingual, he does this. I don't really roll with this idea. I don't think that we should go 2 millimeters here because, again, I kind of go with the leaving the remnant of that palatal area intact. But spatially, these doctors recommend, this full rounding. Okay. You can see the papillas are shortened and rounded to simulate the collapse. 2 lines guide the lingual reduction. Like I say, I tend to go with this, the Jerby method, with no reduction at all on that lingual area at all. And here's why. Because difficulties generally occur with the result of overzealous reduction at the facial, lingual, and interproximal aspects of the associated dental cast. Denture bases fabricated on such cast bind. There's binding involved because there's primary binding sites that are on facial, and then there are secondary binding sites here. And binding comes from over reduction. And this is why then we end up using those stents in order to do trimming. And as you recall, the statement was at the beginning that the least amount, the better. Because for the best residual ridge, in other words, the best bone conserving and maintenance possible, many immediate dentures should be inserted with the surgical procedures limited to extraction of teeth only, which means you have to mimic pretty much just the extraction of teeth and forget about trying to soothsay your way into figuring out how much bone is going to resorb back. It's always easier to do a reline after the patient starts to heal because they'll be wearing tissue conditioner and other kinds of stuff than it is to try to figure out what's binding, and what the problem is. I knew a lot of doctors years ago that would just take rongeurs and they would take them and just crush the bone in, like they felt that was the best way to do it. But we want to maintain bone because without good bone, you can't have an appliance that's, a denture that's going to sit well and it's going to have the kind of support that you need. So remember that both Standard and Jerby, the two that we both are most commonly known, base their respective cast modification procedures upon clinical observations, and each technique yielded reasonable success. So, I have doctors that I still, like I said, I'm doing the the Jerby method. So in adjunct to that, I have to make some surgical trays. I'll show you how to do that. Just to give you an idea here, here's your buccal side, your lingual side, and you can see they all terminate lingually here with no reduction. Here's where all your reduction occurs. Violet's Jerby, which is more, standards in the middle, and then at spatial modeling, they leave more in this regard. But they all reduce from the facial mostly, and it always terminates here with no removal back here on the palatal. 3 methods: aggressive trimming of the cast facial surface may result in binding, as I said. This will necessitate osseous recontouring, relief of the denture and taglio both. In other words, the doctors are grinding the dickens out of the inside of the denture to get at the seat. He's got a recontour bone, goes in there. He's cutting away tissue. It's a pain, okay? And it changes the occlusion. So, insufficient adjustments commonly result in incomplete seating of the denture base and an uncontrolled change in occlusion. So I'd like to rather have a lot of space to start with. So when they place it in, there's a lot of room in there, because there's going to be a bunch of swelling. There's going to be a bunch of, stuff bleeding and swelling. I prefer to and this is why the 2-phase denture treatment is so much better, because the monkey's off your back to perform at a level where the teeth are going to be a nice length and in good positions and so forth, because we're leaving a lot more there, because later we're going to make a denture definitively, which is going to address the things we really can't address without like butchering the patient to get a 1-phase denture in there for an appointment. Now, don't get all huffy, because I know there are patients that have lost posterior teeth in sequence to anterior teeth, and there are cases where a 1 denture will serve patients just fine. But if you want to maximize the treatment, take the monkey off of your back and the doctor's back, and all he has to do then is say to the patient, we're doing 2 phases for you. First one's for healing. The second one's going to be the one you're going to be with for the rest of your life. Okay. Now, I talked a lot there. It's 4:35. You guys got to get moving here. Phonetic adaptation. We can talk a little bit about that real quickly. Every one of my immediate dentures gets this. This is an exact duplication of what's already in the mouth, and that is your long and short branch rugae. I don't put it in by hand. I'm not an artist that way. It's about duplication, not imitation. We duplicate that area. Like I say, I want to have what looks and functions like the real thing. And I want this to be as thin as possible, and I want it to be contoured correctly as possible and as closely as possible. So Pound says the phonetic quality of dentures and their comfort to patients are in direct ratio to the amount of oral voice box that we are able to copy exactly. And that's what I do with my immediate dentures. And that is, you've got vaulted palates, huge, large, and short branch rugae. You've got palatal tori. You've got just, all kinds of stuff. So you got to be able to duplicate that, because that's what that patient has subliminally become used to. So for audible pronation, the tongue must make accurate approximations with the palate. In other words, and subliminally, an overly thick denture in that region hampers the appropriate formation of palatal lingual sounds. Thus, the replication of these soft tissue contours favors the formation and pronunciation of sibilants as clearly as normal dentate individuals. What I'm saying here is patients already have enough to deal with the fact that we're having their teeth extracted, now get foreign objects in their mouth. And so if we can cater to the phonetics for them and make the transition easier, why wouldn't we? Sibilant, by the way, is a fricative consonant by streaming air with the tongue towards the teeth. Words like ship, sip, zip. These are examples. Patients are subliminally locating their tongue on their palate in order to make these sounds. If you make it too thick, if you make it with weird artistic rugae, it's not the same. If we can make the denture only a millimeter thick in that palatal region, we're imitating what's directly below it on the palate itself. This gives them an easier transition because they're not only wearing something foreign in their mouth, but they're not talking like they got something in their mouth, you know. And this just goes, further on for the success of the case. Remember this as well. Once you put that stuff, those in your, oh, by the way, I don't know what that tongue is doing for sibilance, but it'd be an interesting denture to make, find out where that tongue actually goes. But what I was going to say is, once they get this in their mouth, in their denture, they want it when they get the definitive later, and when they get it later and later and later, anytime they get a denture, they're going to want this in there. And they're going to want it put in there the same way, with the thicknesses being identical and the replication. Dr. Pound's technique used swedged foil. He basically took the palette on the model and he swedged a thickness of foil over that area and then put it aside. And then later, when he was finishing up the denture, the immediate denture, he would wax it into place. It's okay. It'll work. But I found that the foil tends to be a little too malleable, kind of easy. It's hard to pull it and put it back in place without folding it. Like, even you can see here, he's got a couple little folds and stuff in it. So I thought, you know what? There are modern materials that we can use that we can make this form without foil. Before I go there, though, I'm talking about artistry. This is hand wax. It's got nothing to do with the actual patient's function, but they wanted to be artistic, so they did this, and I'm sure they got a lot of likes on Facebook because, woo, we spent some time and really made that look good. But it serves the patient no real value whatsoever. Unless that's identically placed over the top of what they had, and that's what it looked like in design, ain't happening. They reject that so fast, your head will spin. It just isn't happening. So, I just mentioned this because it's all about imitation. It's not about artistry. It's about imitation. We have to imitate if we're going to help that patient. Rugai transfer, identical replication, has a couple of benefits besides this benefit where we have everything right above it, and I'm going to show you how I do that. But it also gives us a uniform thickness and a uniform shape. I'm able to follow the contours of the vaulted palate to give it exactly the amount of room the tongue needs, because the dorsum of the tongue is going to sit in there and regulate air. It has got to have the same amount of space, and if it does not, then again, we're back to square one with the patient trying to adapt, okay? So what I do is I set the case up and I wax everything final except in here. And what I do in here is I put everything like it would be in fullness all the way around. Fullness from the mesial, the first molar distally, and I allow the dorsum of the tongue, that's the fat end of the fat sides of the tongue, to sit in there. That would be the area where they would be most, it'd be closest to. If there's teeth back here and we do extractions, I make a mental note. But basically, this is the area where the dorsum is going to sit, and we leave this area open. You'll notice I also leave the papilla open, incisive papilla open, and teeth are always front of that anyway, so this should always be exposed. And by the way, if you're making a rim for a denture and you're over the top of that incisive papilla, it's not correct, because the papilla, the rim is going to be anterior of that papilla. It's not going to be directly on it. And if the doctor is doing a rim try-in and he's trimming the rim and he's checking for 55, 66, if that's too thick in there, it's obstructed. The best thing to keep in mind is it's 8 millimeters forward of the bisection of the papilla is this in this direction is the default. Okay, so anyways, everything is waxed into this position. Width is established with a slight depression in the premolar region, slight depression in here. Air regulation, dorsum of the tongue, width. So then I imprint that area with a piece of putty, GCLT putty with 84 char hardness or any suitable substitute. I have this already in place because that's going to give me my landmark. So when I trim this, this will fit in right between all the wax up, because I only want to replicate that area, okay, which is in between. Make sure to impress the entire wax periphery in order to indicate the wax border, as I just said, needed to indicate to replicate the border form of placement. Right there is what we're replicating. Then I vacuum form O2O coping material over the top of that, and then once formed, cut to a periphery border. That's the border where the wax starts, indicated by the wax area. You should be able to take this form and stick it in the middle of the palette, and it should like rest right on the palette again with no obstruction. Nothing should be holding it up because it should be slightly smaller than where the wax border is. Then I take and I cut a piece of wax out. You could use a square here, a square here, and a square here. I tend to use one square. I warm it up, warm it, not melt it, warm it up enough that I can depress it first and get the contour. Then I take the form and I place it right over the top of it. And because this is uniform and because this follows a certain shape and so does this, it's about 1 millimeter off the floor of the model. And then I wax that area in by hand and smooth it real nice so that there's no transition line. And I get myself, that's the area. Now it's all duplicated from the papilla to the long and short branch rugae to where the dorsum of the tongue sits, like that. Side benefit is that contour, like I said, and maintain thickness throughout the entirety. Some different examples, one here, one here, one here. You can see the diversity of the palatal rugae. It's quite distinct. Each one has its own different little qualities as far as thickness, vault areas, and long and short branch rugae. Okay. Surgical guides quickly. I'm moving right along. Proper contour of the master cast to anticipate bone loss, reduction of bony prominences, tori, tuberosities. Somebody texting me here? No. Reduction of bony prominences, tori, or tuberosities, or reattachment of the mucogingiva junction at a desired depth may be necessary. In other words, what I was talking to you about with the different philosophies of bone trim and how it should be most conservative as possible. But like I say, I still make a surgical template when things like that cannot be accomplished, especially if the patient's got a lot of ratty tissue and I don't know how much bone has been destroyed underneath the tissue and so forth. But Frank Farmer, or I should say John Farmer, surgical template, fabrication for immediate dentures. That's the article I got it from. Materials I use, lab putty, 84 Char, Proform surgical tray at 0.100 or suitable substitute. Industrial scissors or stiff Robinson brush for removal of the excess material around the vacuum form, and then Z-Bird carbides and mini Scotch-Brites to finish. Those are the mini Scotch-Brites on the right, vacuum former you know about. Once the form is vacuum formed, I take and I use a Robinson brush stiff and I go along the edge of the border all the way around and take it off. It cuts real nice and clean. If you get it to the right speed, if you go too fast, it burns the brush away. And if you go too slow, it doesn't cut. There's a nice speed with your micromotor handpiece. You can get it at where it cuts just like butter. It comes right off. We'll throw a bunch of material, put your vacuum on so that you don't have to breathe in the bristles. That's 0.100. The technique, closer to replication, the actual denture. Okay, so I kind of went out of sequence here a bit. This is after I vacuum formed. But how I actually get the form to vacuum form is really what we're looking for, which is that I use putty to go on the inside of the finished denture. That means the denture's done, complete. Borders are polished, everything. Now I go back and now I make the surgical tray, which is that I submerge it until I have a full encapsulation of the flange. Then I cut it back, pull this off and cut it back so it exposes the junction because I've got to vacuum form this. So it aids in forming and thins out the base if it's too thick. So in other words, if this is too thick, you can always thin it out because you want the thin as you possibly can, because the closer to the platform that the shape is at on the vacuum former, the better adaptation you're going to get on that model, because you're going to vacuum form the inside of the impression of the inside of that denture on the vacuum forming, on the vacuum former. Let's go back here. So here's kind of just an idea. It was made, it was vacuum formed, and I have a hole in there. And so the denture, surgical tray is identical to the inside of the denture. You'll notice there's a hole there, and we'll talk about that in a second. But the reason we do that is because these border lengths are established, and so we reestablish them in that surgical tray. I don't take and make a model off of the pre-extraction model or anything else because it's not right. What the doctor's trying to discern is what is holding up a denture from fitting down on the tissue. And the only way to do that is to first duplicate the tissue bearing area of the final denture and then make a vacuum form template in order to discern it. Okay. So there it is that way. Inspect it, make sure that it's complete. Vacuum form over the top of it. For the lowers, you really don't need to place a hole in the center, but on the uppers you do because that will help vacuum form by pulling air from the middle. I'll show you that. Trim and exact polish. This is the exact form of the inside of that denture right there. It's identical. Now when he goes back into the patient's mouth and the denture doesn't seem to be seating, he can place that in and he knows that all of these border extensions are the same length. Everything's the same. And now he can see where it's pressing, where it's not pressing, and make the adjustments. I use, like I said, Comet cutters. Comet cutters I can use also to cut that shape out, Z-burrs, and Dedico rubber, and then it's finished. Okay, that's the lower. I showed you that. Okay, mid-palatal hole is placed for better adaptation of this, but it also serves a secondary and a tertiary purpose. It allows saliva first and blood to flow out of here so that when they place it on top of those tissues that have been brutalized by extractions, that stuff can come out of the hole and it won't hold the denture up from seating. It releases the hydrostatic pressure. But it also gives a secondary benefit in the fact that you have a tactile indication that it's seated because the tissue, he can stick his finger there, but he can see the tissue's right at the hole and there's no space between it. Very important because this is not going to move. Palates don't move because that's bone. And so he can press that up. And if he takes his finger away and it pushes away, he can then push it up and then look and he can discern where he has to make any adjustments if there are any to be made. So it's to relieve the hydrostatic pressure, and it's also to give you a visual indication and a visual and tactile indication that the stent is seated. That's just a case where it's done final. That's an immediate, and then just stick that on there. By the way, yeah, I try to make my immediates look as good as possible. There was that case you could see. This was there was so much ratty tissue on this one that I did some modifications, but you will notice that I never touched the lingual area and I left it fat in these areas because I don't care if it's going to have some space in there. I want it to be sloppy so it can be relined later. There's that hole. Just to show you the denture and the stents. It's a kind of artsy-fartsy thing to show. And that's that. Fabrication. Okay, I use microwave curing for probably 80% to 90% of my work. When it comes to immediate dentures, I always use it. It's just wonderful stuff. It works really quick. Under an hour, I'm breaking it out after I process it. You can process when you process in a microwave oven, it's 3 minutes in the oven. You take your flask out and you put another one in microwave. Take the flask out, microwave it. In other words, it doesn't tie up the machine. You can do 2 arches in 6.5 minutes, 3 minutes on each, a half a minute to change them out. And then they're sitting on the counter for the rest of the time cooling because you have to allow them to cool. That's the biggest thing about microwave is you have to allow it to continue to cook as it's cooling, like a steak. You take it off the grill, it's still cooking. Cycling, 500-watt oven is what you get. You get at Wally Mart for $70. Set the cycle for 3 minutes, remove the flask, bench cool at least 30 minutes, lukewarm water for another 15 for a grand total of 48 minutes. I say important asterisk because you have to allow the cooling sequence. GC, I'll give you some math to get started. Maybe I'm thinking about it, Zaleske. GC Nature Acryl MC, a pound kit, $62, right? 16 arches is what you can make from a pound of acrylic, in case you didn't already know that. You should know that if you're running a business because you have to know what the yield of your product is. But 16 arches at an average cost of $3 to $3.25 to $4, depending on where you buy it, per arch. $125 is the LMT, fees, they quote the fees. I forget what I called that earlier, but anyways, they say the average for that fee is $125 to process 16 arches, $2,000, which means for a $62 investment, you make on a minimum of about $2,000 or $1,938, $38. Microwave oven costs you $60. So guess what? You've already paid for that with the first pound of acrylic. And then you got a microwave flask, and that pays for the first one too, because at $2,000 just to process, take the $300 off of that, you're at like $1,600 for that first pound that you bought. So $422 investment, bingo, and you're on your way. Done. Microwave curing, there's the flasks. The only ones that I recommend, by the way, I have others in the market. Some of them, after a few times of using them, they start to leak when you fill them with stone to invest. Pain in the ass. These are rather robust. You have to use them the right way. If you want to know more, go to my YouTube channel, Tom Zale 56. Just so you know, conventional curing, the heat comes from the outside of the mold inside, which means that there are large temperature differentials in different areas of the flask as the heat comes in. At the pins, it comes in slower because it's thicker. Maybe this comes in slower because it's thicker. This is closer to the front. So all of that heat is coming in at different times from the outside of the flask conventionally. So you don't get a uniform cure at one time. And so it goes from the outside in, not good. Better, microwave curing provides a rapid rise in the center with little temperature variations because there's nothing blocking it from coming in at the same rate onto the inside. It starts on the inside and goes out. So it provides a uniform cure, and this is why I'm also finding I have real nice fits, post-process fits. I have to do a little minor occlusal adjustments in the plane of closure areas, but basically they fit like a glove. They go back on the articulator, remounted, and there's very little to adjust. Anyways, that's the reason. The packing closure, 850 PSI, final closure is 1450. Here's the thing everybody does wrong. They take the flask, they press it, they trial pack it and everything. Then they take it out, and then they try to put it, then they try to take and tighten the bolts with it out without it being under pressure. And so what happens is they're trying to use bolts to bring it back to 1450 PSI, and the bolts fail. Maybe not immediately, but they fail. So what do I recommend? Well, first off, I recommend that you use an oil or hydraulic flask press, one that the bottom fits on. Now mine is the Mistra, but there are other people that make similar, or if not the same, and they're private labeled, I don't know. But anyways, I lower this disc on top because it clears all the bolts, but they're very close. So what I do is I put a black magic marker all the way around them when I know that I can turn all three of them when I first get them. And then I have a referable mark to go back to every time I close it. I don't have to keep sliding it around to get it to where I can turn the bolts. Anyway, on your final closure, you close down to around that circle, which would allow these bolts to be tightened. And then what you do is you take and you hand tighten those down until they are snug, as much snug as you can all the way around. It's under pressure now. It's under 1400 PSI. Then you take your wrench and just knock it, like I'm talking a 30-second of a knock, just to cinch it just a little bit, and then take the pressure off. You won't break the bolts because the bolts are not being forced to close a flask at 1450. It's already at that 1450. All you're doing is you're just meeting where the resistance point is and holding it at that point. And then once you take the pressure off. So the cool thing is, and you can read the research on it, because I had an arm wrestling match with a guy online who tried to say that there was no benefit to never taking the pressure off on final closure. Yet I found articles on the Journal of Prosthetic Dentistry that refute that, and they say that it indeed has a benefit for the final closure, never having the pressure come off. That was always been my argument for conventional processing. Also was that we do all this stuff to get it just the right closed, just the right way. Then we take the pressure off. Then we take and we put it in a flask compress, and now we're using those springs on that compress to bring it back to the amount of PSI that was on the final closure. But you've already relaxed it. Now you're trying to get back. And that's why on the Mistra set, they have clamps that I can also put those clamps in this press, slide in my conventional brass flask, close it down, and then close down the bolts on either side on that. I'll tell you what, it's awesome. I get that final closure. And if you're curious, Jörg Stuck, there's a JST flask from Candelor, and they have brass flasks that also have those bolts like this on the brass flask, and it's all tight in that way, and it's promoted as being the best way to do it as well. Done. Some things about microwave: dimensional accuracy and denture resin cured by microwave. Conclusion: I'll just get to the cut to the chase. Microwave processed denture bases had equal or better dimensional accuracy than conventionally processed bases. And by the way, that was in 1991, and that was by the Eastman Dental Center in Rochester. So if you want to argue that point, see Dr. Wallace or Dr. Grazier if they're still alive. Comparison of the bond strengths of microwave to water bath cured dentures, which I've done for a million years. 1990 study showed that the results showed microwave cured PMMA demonstrated significantly higher bond strengths than conventional PMA, and that priming of the denture tooth surface with monomer liquid yielded even more significantly higher bond strengths than other treatments that they tested. And that was in 1990, just so you know. Microwave is happening, man. I'm telling you. Microwave polymerization of acrylic resins used in dental prosthetics by de Klerk in 87. Microwave oven cured resin had this is cool, had lower residual monomer ratios and the same physical properties as conventionally cured resins. Why is that cool? Immediate denture, first time patient's ever going to be in contact with any kind of residual monomers at all. Isn't it nice to know that the immediate denture has the lowest residual monomer based on this study in comparison to the heat cured stuff? Just worth mentioning. Did somebody tell me I'm done? Better not. I'm not done. There's your stent, immediate denture. Just to show you, I go thin, baby. And that's microwave cured resin, and I'm not getting them back saying, hey, they broke or anything. They actually are very robust. They're a little more transparent, but then the other part of that is, too, I'm so thin that, I just, I don't want a patient walking around looking like he's got chewing tobacco underneath his front lip. I want them to, look comfortable, be comfortable. There's going to be enough swelling without having something that's 2 millimeters thick in there because somebody's worried about it breaking. And remember, hey, that's another thing. Dentures, they don't break from the palate out. They break from here forward. If everything's balanced and correct, off the bat, there's no stresses because there's contact pressure all around the dentures distributed. It's only when the teeth start to wear on like an angle, then you get the wedging effect that these things end up breaking. And besides that, in several weeks of treatments, tissue treatments, and then a reline probably, this is not going to even make a difference, this thinness, just so you know. There again, just to show you, I don't skimp on making sure things are thin. I want the patient to be able to adapt. I sift off fibers, though, because I don't like fibers in between teeth. So I take a small amount of my pound, if I bought a pound, a small amount, and I sift out all the fibers with a teeth strainer. And then I sift that non-fibered acrylic around the necks of the teeth and wet it. And then when my bulk of acrylic is ready to pack, which has the fibers in it, I pack that in there. What it does is it gives me a non-fibered papillas. I hate fibers on papillas. And it gives it almost like a characterized look because of the fact that you have no fibers and then you have fibers. So the redness of the fibers is what kind of gives it that color, that polychromatic look. Okay. Anyways, if you want to know more about that, you know where to go. There's a denture, immediate denture. You can see, just wanted to show you, post-dam, palpated, post-dam, the whole thing. You can see this was a socketed case. Doctor asked for a socketing. I do socketing if you ask. It's what you want. It's what you get. You're still getting that template, though. Okay. Here's one special request. Wanted this incisal edge erosion when we make the immediate. All right, and so I basically used Optiglaze color and put some erosion islands that were the same as these erosion islands, like these, and ground them in with a little handpiece carbide tip. And then I took A plus because it was an A shaded tooth, and I darkened those and came up with that. So I shaped it, aerobrated it, Optiglaze A plus. And by the way, one coat of A plus for the first shade range, another one darker, another one darker. You have to cure in between each one of those applications to get each level of darkness. I'm just checking to make sure nobody's telling me to quit. Optiglaze clear on top of that, and then cure. If you want to know more about that, you know where I'm at. I also like phase 1 dentures. I don't skimp if a patient's really wants a natural, supernatural looking immediate band-aid, or even a final denture. I do pits and fissures with the Optiglaze color, and you can see here, you get a nice result. Hey, Zaleske, does it wear off? Yeah, it probably does at some point, but if you'll notice, I'm only doing the pits and fissures. I'm not doing the cusp tips. I try to make everything kind of lingualized, so the contacts are coming here. But the fact of the matter is that no, they pretty much stay in place because it has to wear down through the pits and the fissures in order for it to make a difference. You'll also notice if you look close, I have some ground areas here because this was in opposition with something where I had to grind. And so what I have here is a little darkness there because I would still have an erosion and it would change and create a polychromatic effect on that tooth. Same thing here. Anyways, just another thing that you can do to bring up the level of your work, deliver something nicer to the patient. There's the case, the upper arch. You can see it has all the bells and whistles, long and short branch root guide, blah, blah, blah. Okay. We got left here, fabrication. We're at Jack. Jack, just a case to show you real quick. Just a case, real quick. There's a Jack. He comes in. He's a mess. So we get pictures, lots of models. I take measurements. Remember I was talking about gingival zeniths and lengths of teeth, and then I can compare. Is that a good length? Is it a bad length? This is a tough case because this guy's murder. I mean, it's bad. His final denture, his definitive denture later is going to be much better. This is just a Band-Aid, but this isn't a bragging course or lecture. This is just to show you the way I get to a certain point. Okay. So, anyways, I compare the lengths of what he's showing. All this is in models. I make some measurements. I get my first contact point like I showed you on that other case. Here's where the first contact was. I actually use a piece of pattern resin here to hold it in position because I got to take that pin out. Recall I used putty on the other application. I used this one. I used a pattern resin instead on this one. That's to hold everything up because I'm going to start knocking teeth off and everything else. But I also do some other stuff. I like scribe out where I want the borders to be, how long. I scribe out the length of the teeth here. I'm going to be very conservative with this guy and let the doctor take away any of that ratty tissue you saw in the picture. But I have to have a baseline to start with, so I sketch everything out so I know where it's going to go. It's called mapping. That's what I do. I actually took some measurements here. And then, of course, the first contact point. There's a contact point over here. Then what I do is I also measure from the incisive papilla outward. I had nothing really to go by because that was a partial he was wearing in the picture to begin with. So I did some figuring and measured out. I forget the exact amount it was, but it was like 8.5 or something. I got that in there so I could get a baseline for the set of the anterior centrals. I also used that plane to come across from the 1/3 up the retromolar area to give me an idea where the plane was. And then I also wanted to see the shape and everything of the teeth, so I dropped a piece of black cardboard, or construction paper, I should say, behind them because I wanted to highlight the shapes and what I had there to kind of start to get me into an idea of what I'm going to have to do. And one of the problems was that I saw that he was retruded. So because he was retruded, I have to tilt it forward because the patient, doctor doesn't want the patient to be that far retruded. So, I take another measurement with a straight edge and I figure out exactly how far tilted forward I want. I think I missed on this. But anyways, then I start knocking teeth off, setting. I've got these two in place based on the measurements that I showed you earlier. Add a tooth, continue to add teeth. You can see here's the bisected papilla. I'm trying to follow the arch form. I'm not real sure if this came in a little or not. I'm trying to split the difference. Again, you know, these are all crapshoot. We're trying to minimize the amount of odds of going wrong. Set the teeth in, and I tilted them forward. I gave them a little bit of incisal erosion since I know I'm going to be remaking both of these for the definitive later. You can see here's the pattern resin. It's not sticking to the other side. It's just it's indexed and it holds in place, so I can continue to extract stuff and keep that pin out of my face. Anyways, continue to set the case up this way. Again, you can notice I'm doing mapping down here, and I've got all my lines in place. And then what I do is, because I want to have a uniform thickness, I don't want to be grinding a big hulking thick flange, I'll wax in that along that line a thickness of border that I want, and then I'm going to keep that thickness through here and be able to thin it out. But you'll also notice I do something else. I wax in full around the necks of the teeth, because nothing bothers me more than when I can see a white line through the tooth is short of the acrylic, and I want something to be, you know, I want it to be thicker so that there's a nice junction there. I don't want it to look like a tooth laying on a piece of acrylic. I still want to have that emergence look. And because I want to have that emergence look, I wax this in and I leave this last. Okay, so get it all in there. You'll notice I couldn't get away from this sway, not based on all the lengths and everything I had. And again, one of the cool things about the two-phase immediates is just that you don't have to worry. So anyways, I got him in a functional position, and then we can go back if we have to. There'll be some modifications done on this transitional immediate that will then be transitioned over to the definitive later. Then I fill it in, as I filled in here, and put in my contours, fill in here, get everything all squared away, and go to town. Then, of course, I put in the palatal rugae transfer. You know, I like doing this occasionally too, a lot of times. I like to extend the linguals of these teeth, especially if I've ground on them a bit. I want something to define that there's a tooth there, and the patient can feel those linguals back there a little bit. I like to just put them in there. It also secures them in place a bit, you know. And I also make sure that, you know, on these immediates especially, that I give myself some good diatorics, because there's going to be a lot of knocking around, grinding, and everything else. I just a belt and suspender guy. You'll also see the imprint of the rugae transfer here. You can see that this case was trimmed. Nothing was removed from here. You'll notice I didn't go over the hamular ligaments. There's the butterfly. That's the immediate. That's the phase 1 immediate. There'll be another one made later. And again, you know, I use a nicer tooth, that Gebde Tribos teeth. I dig them, but you know, I had to be short here, you know, because I didn't want to be too aggressive, so I was conservative, so I couldn't get the full length of these teeth. That'll be addressed later, because there'll be bone resorption and everything when we make the definitive one later. But I think it looked pretty good out of the mouth. In the mouth, close. I'll show it. You'll see it. Anyways, again, pits and fissures, thicknesses, everything that I mentioned earlier. Occlusal enhancements with the optiglaze. Here's the inside of the denture. There's those teeth that I tilted outward. Remember, he was inward. I don't think it flew. There they were, complete. There's the templates made off the finished dentures, not off the models, as I mentioned. There he was. I think that we might be off on the incisal edge length. I gave it character. It doesn't look like that other thing he had in his mouth, but it's not bad. So anyways, as I said, those anterior teeth weren't so, lower anterior teeth weren't, we didn't like the way they were placed. Doctor didn't like them, he didn't like them. So he comes back and he says, well, let's reline and replace it. So, you know, reline and replacement on this case, on this part, not so much. I didn't do a reline and replacement. This is a reline, but this is a reline and replacement. And what the reline and replacement is, that I took off this section. He took a reline impression. Then I took off this segment, and he gave me a bite registration, because I was going to do this reline at the same time. And then I reset the case and put the teeth more where they should have been, based on his bite and some conversation that we had. So I replaced them all in one fell swoop. I just invested it in the closed flask reline technique. I prepared the surface in a rough fashion and removed all the undercuts, cut out the window, and the anterior teeth are still in the upper half of the mold. You'll see that in a second, and took it down like this. So that's how they look prepared, ready to go back into the flask. See, they were covered with putty and then invested the second half. I'm sure a lot of you know how to do that. Anyways, and on the lower, I left these stuck in stone so they wouldn't move. And then this came out because the rest of it was in putty, and those stayed in place. I was able to grind everything off and leave that huge window where then I can pack in the acrylic first and then pack it through and do a couple of trial packs and then process the case with a reline and new teeth. I didn't want to do any self-cure nonsense that was going to get ugly and stained and everything. I wanted to make sure that I could make it look nice and presentable. So there was the original, just to show you how things change. Here was the original denture, okay, the original immediate, and here was 8 months later with a reline. And you can see the stuff that gets taken up. You know, it's quite a bit, resorption and everything else. But again, you know, I just want to illustrate, this is why I stay conservative, and this is why I always recommend the two-phase rather than the one-phase denture, is because there's so much change that occurs that we can correct all that stuff in the final denture. It takes the onus off the doctor to perform it a super high level, and the patient's expectations don't go off the map. All right. And then the lower, same thing. Look at that. That was the immediate original, and here it is, the final 8 months later with this reline. You can see I added acrylic in here where it wasn't in this before. Remember, I had to get more lip support. There was a bunch of things I had to have. And that was accomplished by cutting out that window and relining it and repairing it at the same time. All right. So there they are. That was prepared, and that's the final. And that's, oh, by the way, that's all microwave. Not really. Did you notice? See, it wasn't microwave because I wanted to make sure that I did this last one with the super high impact material just because they were coming back for an enhancement. I wanted to make sure everything stayed cool. Not that I didn't think it wouldn't, but I just went that route. There it is, original, 8 months later. See the differences too? They had no fullness here. It got fullness in here. These teeth are set differently, closer. I had to bring them out further. But you can see, pretty much stayed the same on the upper. Cool thing is, the reline, you can't see any line of demarcation or anything else where the new and old acrylic met. You can't see where I put old and new acrylic in here. Great technique, great stuff. Original and modified, you can see the linguals. See the difference? This one's out further, and this one was not, I was afraid to come out too far, but it needed to come out further to make the case successful. So anyways, you know, like I said, that was the phase one. I'm hoping that the phase two is going to be better. I already know some things I'm going to do. One of them is I'm going to change this incisal edge course. I'm going to leave that lateral in a little bit. I might even depress that one a little bit. But all in all, those are the things that I did to get to the end result. You probably will get a better result on yours. Lastly, end results real quick. I don't know where I'm at, 516. Refine your skills, broaden your dental knowledge base, then arrange your thinking. This is Alan Brewer. Alan Brewer said, you refine your skills, broaden your dental knowledge base, and rearrange your thinking, and you will then have no failures, only varying degrees of success. So if anybody says you had an unsuccessful case, you just say, no, I just have varying degrees of success. It's a nice dodge. Virginia comes in. She looks like this. You saw her picture earlier, but not her before and afters. There's what she looks like after. It's not even the same person. Using those techniques, okay? Lydia comes in like this, goes out like that. We have done some lower work on her implant bar. This guy here, he had I don't know what kind of disease. He was going to get all of his teeth pulled. And he was also having some multiple amputations. Anyways, I tried to do the best job I could for him. And he had a nightmare of a mouth. But we had enough in place that I think we did a nice job on There's his immediates, upper and lower. And I was glad to know that I could help him. We have a nice display of tissue and a nice shape. I think I did him right on the shape. Anyways, a success using those techniques with the Rugai and all the other stuff that I do. You saw this guy. Oh no, this is Ken. He's a different guy. He's another wreck. Again, these patients, you know, we're trying to give them something you can see. He didn't want to restore the lower. You can see why. We're taking it a step at a time, but not bad. Immediate dentures, man, they're tough. And that guy, Ken, we didn't even put posterior teeth on. We put blocks on him. That's why it looks open over here. You might see that, oh, well, how you didn't have those teeth out. Well, there's teeth in there. It's pink. So it looks that way. Because if I had teeth in there, see, what I would have been able to at least give him some white fill in the negative area here. But I couldn't because there were two blocks. It was a transitional appliance, and he was resisting treatment. The doctor just wanted to get him in something, and we had nothing to occlude against other than those beat up teeth, and we didn't want to put actual denture teeth in there, so we did it this way. And then finally, Lydia. I don't have any befores on her, but she was just delight. She had a facial asymmetry. She had a stroke. She had this curve here. She had a passive and dominant part of her face, and we addressed it with a nice smile line. That was a tough case, but it turned out nice. Anyways, that's it for me and my segment. Let me get out of this. And if there's anybody left, I don't know. You probably all like ran. But anyways, if there are any questions that you would like to pose, and if there is anybody left to pose them, I think that. Oh wait, Texas on the phone. Hello. Yes. Hey. No questions. The green ones are the microwave flasks. Those are GC. Yeah, I did the best I could with what we had to work with, Rich. Thank you very much, Texas. And I hope that I can come back soon and see all my friends. Um, last weekend in March, will you please? I'll tell you what. I'll have a bourbon for you guys. How's that? Okay, Richard. Thanks for the opportunity to help you guys out, and all the best with the rest of the show. No problem, buddy. Talk to you later. See ya.